When we first started our CAIRS program, we were manually punching the cornea. In fact, we were using the Susan Jacob double punch. Then there were some FDA issues with that, and so we were using 2 different punches to prepare this. But what we found in looking at OCT is that the thickness of that cornea varied greatly from one side of, say, an arc to the other side. And you can see that in this image, 990 microns on one side to 550 on the other. And that should be expected. Corneas that we're processing have variable thickness. Some of them can be 800-900 microns by the time we get to them. And so if you consider Bérequer's thickness law, it talks about that tissue volume determines the biomechanical effects on the cornea, right? So if you don't know the thickness of the cornea, of the CAIRS segment, then technically you don't know what outcome you might get, right? If you have 990 is the volume versus 550, you'll have a different flattening effect. And we do work with Susan Jacob as our consultant on this program, and she talks about her quote, "When the segment's volume is intentionally and predictably varied along its length, surgeons can create a precise surgical plan using thickness and width engineered to control the biomechanical impact." And this is supported by her work with customized CAIRS. She does this intraoperatively. She's an artist and takes the time to create these grafts for her individual patients. Many surgeons may not want to do that, but she is just amazing at what she has demonstrated with this. But she talks about the variable volume, the arc length, the taper length, and the gradient of the taper, and demonstrates that there's a significant difference in flattening when you're able to create these grafts, customized grafts, within that tunnel. This is certainly supported by the work that Shadi Awad has done using a femtosecond laser to create different shapes and sizes of CAIRS arcs. And his conclusion in his articles, and there's been more than one, is that the femtosecond laser cut CAIRS procedure improves visual and tomographic parameters and allows repeatable and safe results with the possibility of customization for individual patient management. We've done our own work internally. Dr. Eric Abdullayev, we invested in a Pentacam just 8 months ago, and we're performing our own work to demonstrate this. I'm not going to get into great detail on them. I would say that they're proof of concept studies that we will be working over the next month or two to, yeah, we see your picture there. We basically performed 4 studies. One, we took a normal cornea, put on the Pentacam, then implanted a CAIRS graft of different widths and demonstrated increased flattening with the more volume that you add into that channel. Then we actually created cornea ectasia using type 1 collagenase. We took that a step further and created some specific phenotypes, a snowman phenotype and a nipple phenotype. And then finally, creating that ectasia, we then did some CAIRS implants and have been monitoring the amount of flattening based on the ectasia that's been created. So all of this led to our reintroduction of CAIRS, Optograft CAIRS, and that is a sterile, laser-cut, predictable CAIRS keratoplasty outcome. Some of the way that we go about that, we use this high-pressure anterior chamber. We've been using this for years to do our ultra-thin DSEC. We put the cornea under very high pressure. You can literally see the edema, the fluid come out the anterior cornea so that we normalize the cornea thickness. Then we take that cornea and put it on the femtosecond laser. We cut 550 microns. All of our grafts are one thickness, 550 microns. We vary the width, and that's what we're demonstrating, that the width variant will change the amount of flattening, but we keep it all at 550 thick. And then we package it, seal it, and do terminal irradiation. We use E-beam irradiation, and these grafts are sterile like any medical device, and they can be stored for up to 2 years at room temperature. The studies that we demonstrate, very different from the manual cut, very consistent thickness across the individual arc. So from 508 to 520 microns, much different than that 550 to 980 that you saw with the manual cut. And when we dehydrated these in room air, we also saw that they were very consistent in how they dehydrated, right around 200 microns. And so we, working with Zimmer, they have created for us some software so that we could do not only different widths, that was the easy part, it was the different shapes. We have a crescent shaped and a tapered shape in different widths. The tapered is something that we are actively working on, and we may not have that available for the next 30 days, but we should have that soon. I'm looking at my director of operations when I say 30 days, right? And so our portfolio, again, all thicknesses are the same, 550 microns. The concentric arcs come in different widths, 0.5, 0.75, 1, 1.5. The asymmetrical tapered arcs, we intend to have 1, 1.5, and 2. The asymmetrical crescents, 1.5 and 2. And then again, we're using the laser to create a 20 micron Bowman's membrane. And we're excited to work with people to kind of explore that once again. Bowman's membrane was getting some excitement, but the manual dissection was so very difficult. We were talking with Dr. John Parker and the work that they did with Bowman's, and many people backed away from Bowman's just because the dissection was so very difficult. With the laser, not so difficult. Expensive, but not difficult. And then we worked with Rumex. If we have different widths, then if you're going to do a manual dissection, we want different sizes of the dissector. And so Rumex has created different sizes that will be paired with the width of the cornea, the CAIRS that you're going to be implanting in your patient. So one, I appreciate you all being here. Such an honor to see some very friendly faces, people that work with us year after year and help us to perform surgeon training. It's really a pleasure to have you at our facility, and I will be around all day.